Hi, everyone. I'm Brinley with HS Connect, and we are here today with Dr. Barry Resnik to talk about CO2 laser treatment and surgery and what kind of an option that is for those of us with HS. We understand that it's fairly new to the HS community and seems to be making some headway. So we wanted to get a chance to talk with Dr. Resnik about this and see how this can offer those of us with HS some other options. Can you explain to us, Dr. Resnik, thank you so much for being here today, first of all. I appreciate you taking the time to do this with us. Can you explain to us in layman's terms, for the most part, as far as how CO2 lasers work?
The particular kind of surgery that we're talking about is better called CO2 staged marsupialization for HS, because in the past, CO2 lasers, which are primarily destructive, they ablate tissue. They have been used to go over an area of HS multiple times until it's hamburger and allowed to heal, but it's not what we are doing with the CO2 laser. So what we're doing is we are outlining a scarred plaque, what I call an ant farm for HS, because it's got all those tracks that are running through the skin and interconnecting and having multiple openings. So we're taking that plaque and we're going around the outside, and then we are dissecting it off of the fat, making sure that we take every tunnel, every fistula is opening and not leaving anything behind. So the defect will be as big and a little bigger than what the plaque occupies, but it won't be deep. And the goal is not to have recurrence. So if you think about it, you have a patch of dead grass and you dig all that dead grass away and you make sure that you don't leave any chinch bug behind. And then you make sure that you go around the border and you make sure you don't have any tunnels left. And once you do that, you've got clean soil, and then the grass grows in over it. And what you've got is a leftover scar. That's what we're doing.
That's an excellent description. Thank you. How does it differ from wide excisions?
The understanding of where the disease is located, which is in the skin alone, and where it's not, dictates how successful or not successful a particular procedure is going to be. Typically with en bloc excision with primary closure, which is how it's referred to, you're taking out a really big piece of tissue because you want to get it all, we'll put that in quotes, and then you're trying to close it in a straight line. It's really difficult to close a circle or an oblong or whatever defect you've got in a straight line. It compromises your range of motion. You end up with little poochies at the ends because trying to bring a circle together ends up leaving poochies. And it's a really tough healing time. The line breaks down, the sutures pull, the staples pop out. If you're having a skin graft or a muscle and skin graft being moved from another part of your body, it's a very debilitating, non-functional healing time.
So is the healing time for the CO2 laser then dramatically less than it would be for a wide excision or even wide excision via second intent?
The healing time is a functional healing time, because when you have the procedure done, whether it's in my office under local anesthetic, the same kind of anesthesia that we use for tumescent liposuction, or if it's under general anesthesia in the surgical center, you're walking out or being wheeled in your wheelchair out to your car, but you are walking out of the hospital or the center or the office and you're functioning because you're getting up and you're showering and you are hugging your loved one and you're picking up your kid. It's a tolerance, but it's functional, and you're changing your bandages just like you do. Every HS sufferer is a skilled wound care nurse, and you're changing your bandages, or you're having your spouse or significant other help you with that, but you're moving. Most patients go back to some kind of work or some kind of life by the end of the second or third day. Mostly it's guys who take a little longer because, well, we're guys. But the point here is that you're functioning, and we want you to move. We want to make sure that we don't, walk around holding something. We get a frozen joint or we can't move. The scarring from that wide excision can be quite terrible, quite disfiguring, where with the procedure that I'm doing, we're going for a scar because that's the end point, but it's a scar that looks a lot better than the plaque you had there before. And because HS is a disease of hair follicles, if you have no hair follicles, it's really hard to have HS in the scar.
Perfect. Now, as far as, since it is, you know, more of a new procedure, do you have, what kind of reoccurrence rates are you seeing, if any?
Well, my recurrence rate is about 3%. Typically with the en bloc excision or the wide excision, it can be upwards of 35%. And my recurrence rate is so low because I'm actually running the border. That's what I call it. I am looking with a probe to find any tunnels that I am missing. Now, when we have a recurrence, it's technically not a recurrence because, as I pointed out, you cannot have HS in a scar. But if you've got a tunnel that you've missed and it comes in through the scar, that's what we're calling a recurrence.
Perfect. How do you determine for a patient whether to do a wide excision or the CO2 laser? Is there something that would make you determine, or in your opinion, are they interchangeable at this point and you would always opt for a CO2?
The vast majority of patients who I have in my practice, who I see on a daily basis, are candidates for the staged marsupialization procedure. There are situations where you've got a patient who we would call a early stage 15, devastating disease with so much involvement that there really isn't any place to start, any place to end. And that might be a situation where we're talking about big transposition flaps and moving things around and maybe the need for a colostomy so that we don't have any bowel movement while we're healing. But the vast majority of patients I see are very good candidates for the staged marsupialization procedure.
And do you usually do it, I mean, I'm sure it depends on how vast the area is, but do you usually do it in one fell swoop, or do you do it, I know you had mentioned staged, so do you typically do it piece by piece, or what does that look like for you?
Well, the staged marsupialization refers to the fact that we are outlining, making our initial excision, and then peeling back and making sure that we find each individual cavitary lesion, each individual spot. So it's staged in the context of the entire procedure. But there are patients who have involvement in both underarms, they have involvement in both groins, maybe on a scrotum or a vaginal lip or perirectal, and you can't take it all off at one time. You need time to heal. And the medical therapy here is so very important because getting control of the disease helps the healing. I do not stop Humira, Remicade. I don't stop the biologics. I don't stop any treatment while I'm doing this procedure. My infection rate is 0%. And the reason that most non-dermatologic surgeons will stop Humira, Remicade is because the concept of, well, I'm immunomodulating. I have that possible increased risk for infection. I'm worried about that. So we're going to stop it 4 to 6 weeks before. And 99% of the time when someone does that, the patient's going to flare and they're going to show up for surgery with a full-blown case of HS spilling out all over the place. The surgeons will say, I can't operate on you. You're infected. Well, we're going to have to get you controlled again. So it's a rock and a hard place. It's a constant cycle that isn't helpful. So I know this isn't exactly what we're talking about. When I have patients who need an important surgery, they need a knee replacement, they got to get a hip fix, they have something going on inside, I am advocating for my patients to beg the surgeons not to worry, not to fall prey to dogma that their patient's going to have a post-op infection because they're on Remicade.
Yes, and we hear that a lot, obviously in the HS community, as far as people being asked to stop prior. So can you do the CO2 laser on active flares?
Absolutely. And I have many patients who come to see me just for the surgery. And I have to convince them to go on something to control them. But I've had patients who come in and we do the surgery the next week. That's not something that stops me, because the surgery is removing that burden of HS from their body. So whether it's infected or not, I'm going underneath it. I've done it with active abscess, but I've caught the abscess on the underside. So it's intact, it's trapped within the skin. I put it into the path bottle because I send every piece away just to make sure that I'm dealing with HS, but never stops it.
Perfect. And as far as the, with the growing need for this procedure, how do you see this kind of taking hold in the dermatological realm? And what do you think is going to happen as far as people being trained on this kind of procedure? What does that look like in the future?
My dad's a dermatologist. My daughter is applying for derm residency. I teach at the university. I talk at the foundation symposia, and I talk to all of our friends because I want people to know about this. So when I'm teaching monthly at the University of Miami Residence Dermatology Clinic, we have an HS clinic. That's what we run. So I've got a whole crew of disciples who think about what I think about. Whether they're going to take this and go do it, or whether they're going to go do something else, I don't know. But at least they've been exposed to it. And when I talk to my friends who are dermatologists all around the world and they say, hey, can I come and observe? I said, absolutely. Because the dissemination of this information is really important.
Yes, I agree wholeheartedly. And that's one of the things that, all of these symposiums that are put on and everything else that happens is so helpful for moving HS forward and kind of getting the word out about these things. How do you deal with people who come in from out of town? Like if there's, since it's not so widespread yet, the use of the laser that, the procedure that you do, how do you deal with, do you have a lot of people who come in from out of town to be seen, or what does that look like?
Even before the pandemic, I have been doing virtual visits for all sorts of problems, but HS in particular, because there are a lot of people who don't have access to someone with my passion for the treatment of the disease. So I will see them. They'll send me photos via Clara, which is our secure WhatsApp for the office. And then I'll have my visit with them. It has made it much easier to do during the pandemic, probably the only silver lining here, because I can now comfortably see patients outside of Florida and not feel worried about starting treatment for them. So they'll do a virtual and I'll say, you're a great candidate for this surgery. I'll go through the risk, benefits, and alternatives. And they'll say, okay, I want to do it. And I say, well, here's what we do. You're going to come in the day before, and I will determine with them then whether they're going to need local anesthesia in the office or whether we need to go to a surgical center. And then I'll evaluate them. I need to feel. I need to see what I'm dealing with. And then next day, we'll do the procedure. I like out-of-town patients to stay one day for me, because generally, if something's going to go off the rails, even a little off the rails, it's going to happen in the first 24 hours. And 99% of the time, it's going to be bleeding. So I'll see them the next day, and then they'll get in their car or they'll go fly. And they can do that. That's fine. And then I follow them with Clara. I do them with the virtual visits. I like to see follow-up photos every week. It typically takes about 3 months to heal. Now, if I've got an underarm that ends up being that big, it's still about 3 months. Prolonged healing happens maybe 5% of the time, and it's not related to the HS. It's just a spot. It's healed down, it's healed, and it sort of stops right there. And whether I need to use silver nitrate sticks to chemocauterize it, or I need to see them back to scrape it away, debride, and allow it to heal, or whether I need to cut that little piece out and even sew that up, that's okay. Vastly different from dealing with diseased HS tissue. And they do well. Everybody does well.
And in situations like that, when you're following them via Clara, you know, once a week, and you see that you maybe have some stalled healing and they're from out of town, is that something you may employ like wound care in their city to take care of for them if it doesn't seem like it's that large of an impact? Or
generally speaking, silver nitrate sticks do the bulk of the work. And I've supplied them with them as part of their care package when they leave. I've got a little video online that says, here, this is how you use your silver nitrate stick. I always try to enable their local dermatologists. A lot of dermatologists don't want to deal with something this serious or don't have the ability to do so. But I think that everyone with whom I've spoken in the context of, hey, I've done the surgery for the patient, they're back in California, can you help me with this? They, without doubt, will help.
Excellent. That's really nice to hear. I think that this is especially helpful for people who are outside of Florida and potentially looking at having something like this done. You know, kind of knowing what that aftercare would look like and what the expectations are, and that you do virtual visits, I think is huge for people, because they're questions that most of us won't necessarily ask on our own. So I'm so grateful for you taking the time to do this. Do you have any final words of advice or wisdom or anything?
The best piece of advice to give to anyone with HS is not to assume that you're the only one who's got it. You need to go and find someone who's going to help you. And it may take 7 to 10 physicians, and it may take more than that, but there is someone out there. And I will push shamelessly the HS Foundation, because we've got a list of physicians across the country who really do care about HS and the patients who suffer from it. And we want them to be better. And we will know someone possibly in your area who can help, where you might not be able to find them. And we're always reaching out to new dermatologists to get them on the bandwagon. So HS Foundation, all of the support groups like yours. And if you don't know something, ask. You might have a person who's expert in it in your town.
Yes, exactly. And HS Connect also does have a list of dermatologists, and we have the same ones that HS Foundation has, and we're constantly adding to that as well, especially referrals from other patients who've been to HS specialists. We love adding those onto our panels.
Great.
You know, the more derms we have on there who have a passion for it, the better off we'll be. So perfect. Thank you so much, Dr. Resnik. I appreciate it. I can't tell you how much. Thank you for shedding some light on this. It's new for me, so I know it is for a lot of other people. And again, I really appreciate it. Thank you.
It's my pleasure. Have a great day.